We'll just give 30 seconds to allow everyone to be led into the presentation. Excellent. Well, welcome everyone to the final OC3PR of this season. It's the second part of our two-part series, which began with the history of critical care. And now we'll be taking on the topic of the future of critical care. Given the high aspirations for this topic, we'll be doing a somewhat unique OC3PR, where we will be having a discussion with multiple experts with different backgrounds. I'll admit I have some nervous excitement, as it will be different, but hopefully enlightening and helpful to all. Many of you have been following OC3PR, and for that we are very appreciative. For those who are new, OC3PR is a bi-monthly educational series sponsored by Critical Care Services Ontario. It aims to provide skills and knowledge to health professionals, be they medical providers or administrators. Its ultimate goal, though, is to help ensure that the care provided to critically ill patients is of the highest possible standard. Previous episodes are available on the CCSO website or their YouTube channel. For today's session, we encourage you to submit questions or comments via the Zoom chat feature. Please send them to individuals named Q&A for question and answer. Today's questions are being fielded by Ms. Michelle Stevens and Dr. Bernard Lawless, both members of the OC3PR Executive Committee. As always, we ask you to please keep yourself muted for the session. If you would question about the COVID pandemic having a profound effect on our world, I think you'd agree with me that critical care was affected more than most other areas of medicine. How our colleagues, however, handled the pandemic, though, in Ontario for sure, is something we all should be very proud of. Were there changes? Absolutely. Did we learn a lot? Without doubt. Will critical care be changed, though, because of COVID? I believe the answer for this is yes. I think we'll be facing new challenges, be it staffing, resources, increased role of technology. These are only but some of the ways I think critical care will change. How we shape these changes, how we can adapt, how we can ensure to provide the highest level of care, well, those are some of the questions about the future. As Yogi Berra said, it's tough to make predictions, especially about the future. So since we don't have crystal balls to guide us, we are fortunate today to have with us three experts. I think one of them will remind me that Yogi Berra wasn't the first to say that, but I'll leave it to one of them to tell us who it was. Our guests are also all veterans of OC3PR, so I am delighted they have returned and agreed to participate in today's discussion. Next slide. First, I'm happy to introduce Ms. Carol Young-Ritchie. She's an executive healthcare leader and nurse with over 30 years experience. She has in-depth knowledge and experience in navigating crisis, complexity, and challenges. I was fortunate enough to witness how she helped lead Ontario's response to the COVID pandemic by sitting on the Ontario COVID Critical Care Command Committee, or OC5. She was the executive co-lead of a large academic hospital and was the critical care administrative lead for Ontario West. She is currently a healthcare consultant focusing on healthy workplaces and nursing strategy. Also with us today is Dr. Martin Betts. Dr. Betts is the Department Chief and Medical Director of Critical Care at Scarborough Health Network. He held this role when COVID began and helped lead the Scarborough team, which, in my opinion, was one of the hardest hit centers, if not the epicenter of COVID in Ontario. How well that center performed is certainly a reflection of his efforts. By background, he's a specialist in critical care, internal medicine, and sleep medicine, and serves on the faculty of the University of Toronto. He's had many achievements, including contributing to Ontario's COVID-19 Science Advisory Table treatment guidelines, and in 2021 was honored to be named one of Toronto's most influential by Toronto Life magazine. He's presently completing his MBA at the Rotman School of Management. He's committed to helping improve patient access and giving them the highest standards of care with a desire to answer the question, how do you know you're providing quality care to your patients? By working with patients, administrators, and other specialists, he has helped improve the treatment of critical illness through innovations in healthcare and care delivery. Our final guest is Dr. Michael Sullivan. He was the individual who was truly responsible for the creation of OC3PR. He spearheaded that idea to help other health professionals deal with the unprecedented challenges that COVID-19 presented. Dr. Sullivan is an anesthesiologist and intensivist at Toronto General Hospital and recently was providing such care at the Auckland City Hospital in Auckland, New Zealand. Prior to this, he practiced at South Lake Regional Health Centre in Newmarket, Ontario. During COVID, he was the critical care lead for the Central LHIN, and he too was on the OC5 table that led Ontario's response to COVID. His role on that table was often to be our moral anchor, and he brought his sage knowledge along with his practicality and reasonable approach to issues. The OC3PR team certainly has missed him and are delighted to have him back with us today. Next slide, please. Our objectives today are very ambitious. We hope to discuss the impact of COVID on Ontario's critical care system and consider how this could influence how critical care is delivered in the future. We will also discuss the approaches to critical care staffing, both during the pandemic and for the future. We will explore the evolving role of family members or caregivers, and finally consider how technology may influence the delivery of critical care in Ontario. Clearly, we're trying to be ambitious today. Next slide, please. Our format will be a little bit different today, and for that, we encourage you to do a couple of things. We will present an issue or question to one of our speakers, and then the others will comment on it, and we will then open that up for some discussions with our audience. We want you, the listener, to send in questions that will then further the discussion. To get the most out of the presentation, we encourage you to change your Zoom settings to the side-by-side speaker setting, and the directions are there to go up to the view and pick side-by-side speaker. And if you have questions, use the chat feature and go to Q&A, either number 1 or number 2 for that. Next slide. With all of those niceties in place, we're going to start off our discussion today with the first question being, what are the aspects of critical care medicine do you think will change because of the COVID pandemic? And I believe we're going to start with you, Carol, with that.
Thanks, Dave. And just a first comment I'd really like to make is just how wonderful the critical care community is and was really strong before the pandemic and served us well during the pandemic. And it just, as I've worked with many different clinical programs, great people and great community and great pulling together. So as the pandemic happened, we saw that pulling together go into overdrive. And again, it served us well. I think one of the first things before I talk about the changes is that we learned is that resources aren't endless. And probably for the first time in my career, things like equipment, masks, that we were really missing a lot of things. So our people, we were having challenges with people and our space, our equipment, our supplies, and all those things were huge constraints. We were seeing that with drugs before the pandemic, but certainly as we went through the pandemic, we really learned how to deal with scarcity, and it was quite challenging. And one of the things that struck out for me was very much how close we were to using emergency standards of care and how really challenging that was. So as we talk about changes, 3 came to mind for me as I thought about this question a lot. And one was about building on what happened before the pandemic too. So the first one was really about care outside of the walls of ICU. And certainly that was well started before the pandemic with things like CCOT teams. But the thing I wonder is, can we really take that to the next level? So how do we do that? How do we bring care to patients who aren't in the ICU? So how do we use those CCOT teams differently? Again, we've got good infrastructure with that, but how do we take that to the next level? And how do we take the skills and expertise of the ICU and take that out to patients that may not need ICU and really use an upstream approach about that? Certainly, we know in our hospitals, certainly in nursing, we have a lot of younger nurses, very inexperienced nurses, and we have a lot of highly skilled people in our ICUs who could be providing excellent teaching opportunities. We also learned during the pandemic how much larger hospitals can support smaller hospitals or medium-sized hospitals. And certainly, I was working in an academic center and saw that firsthand, how it was good collaboration before the pandemic, but we really took that to the next level. and help to support some of those physicians and teams in smaller hospitals without transferring the patient. So I think there's huge opportunity not to lose that and continue to do that and support those smaller centers and keeping those patients closer to home as much as we can. And certainly we can do that with leveraging technology. And I think that's a whole other area for us that we'll get into during the presentation also. The second thing I think of with changes is really the critical care workforce and what a toll that the pandemic has taken on our workforce and how things need to change with that. And really a big piece of that is how are we caring for our caregivers? I think, in my opinion, that we pushed people really far during the pandemic with many different waves and pushed people, again, I think, too far. And what we know is that this is certainly having had an impact on people with moral distress, and even now talking about things like moral injury and post-traumatic stress. So really caring for the caregivers and really looking at what that's going to look like. We certainly know, and I've said this before, that many nurses are not going to work in critical care for 30 years anymore. So how do we care for people who are in critical care and that they want to stay in critical care? And how do we keep our teams healthy? One thing that's always impressed me about critical care is how people work together, but how do we keep the teams healthy and reduce that turnover, reduce the use of agency nurse, and again, really promote teams, which we had well before the pandemic. But I think now, in order to keep our workforce healthy, we really need to think about that. And as we think about the workforce, thinking about our professional silos, moving out of those, what could we do differently, and really maximizing the skill sets of people. And I think that's certainly something we still have to think about as we carry on post the pandemic. And the last thing is that I really thought of that we need to think about, and things have changed, is access to critical care and equity and who's getting those beds. This is a tough one, and certainly we struggled during the pandemic. It's tough, but you're caring for that patient that's in front of you, but there's a whole system of care too. And how do we make sure that people are getting access to critical care, and who are we going to move? Something that was quite challenging during the pandemic was moving patients and getting consent from families to move patients. And sometimes the best patient to move was not always the patient to move. So how do we do that? How do we wrestle with that? And that was extremely challenging. And I certainly remember conversations with frontline people who are having trouble having those conversations with family, and it was really, really difficult. So how do we do that? How do we work with our families with goals of care? So those are the three that first came to mind. Maybe I'll hand that over to my colleagues to add any other insights.
Gentlemen.
Marty, I'll jump in and just start. There were, I think two things that I wanted to pick up on, Carol. That was tremendous. Just a real kind of look over things. I really wanted to pick up on this idea of losing our senior nurses. I think that's a really, really powerful change. When I'm out talking to people, I tell them that about 70% of what I know about critical care I learned from nurses, right? And they were often that cohort, that group that was able to guide people, show them along, and teach them the culture, maybe good, maybe bad, but teach them the culture, but also just plenty of knowledge points around things. I really am just gonna, and I'll return to it a little bit later, but I saw this role was kind of codified in New Zealand. They actually have a kind of a senior nurse cohort. They wear different colors, and they've got different jobs, with more focus on the daytime work and that kind of stuff. So it's really, I think that point and that concern, I think, is a really important one for how our ICUs are going to work. The second piece that you mentioned, and I think deserves some emphasis, is this moving upstream. I think there's going to be more room, and I think we've already started as critical care people to see, we've seen CCOT and the advantages that we have there, but I think moving upstream even farther towards the community in terms of the application of critical care as a therapy and who it's appropriate for and who it's not appropriate for, I think are going to be discussions that we've gained some ability to have that we didn't even know that we could kind of organize before all of this kind of came along. Marty?
Yeah, absolutely. Thanks for those great points. And one thing we certainly struggled with in Scarborough was a loss of our real senior nurses. And I think in many respects they felt under-recognized. And I think, as Mike highlighted, whether it's different uniforms, whether it's pay grades, I think recognizing the skill that a senior ICU nurse brings to the table, especially when we've seen our junior and mid-level nurses turn over so quickly, that they really are gold, and they are the eyes and ears of the unit, and they help bring all those nurses along. I think that's something that we really focus on. And the other thing too is, how do we incorporate agency nurses? At one of our 3 sites, we have become really dependent on them, and it's certainly been a challenge for our existing nurses to acknowledge these individuals that used to be their teammates, often weeks or months ago, and that's been one of our challenges. One other point I think that's really probably simple to bring up that I think changes from the pandemic is we got really great at ARDS management, I think all through the province. And that was a real technical skill, but I think it proved to me that if you can really focus on something, you can do it really fantastically. And I think we maybe unlearned a couple of skills during the pandemic because we were so focused on really one type of patient, but recognition to our respiratory therapists who took on so much work and really adopted some increasingly sophisticated ventilatory strategies as time went on. And that was something that will benefit, and our patients will benefit throughout. And I think we're also rethinking the role of immune modulation therapies and management of some particular patients. The last point I want to bring up that Carol brought up is extending ICU supports outside of the ICU. I think we can probably imagine the future in 20 or 25 years where hospitals really are an ICU and or an extension of the ICU. For my teams at 3 of our sites, we had in-house ICU physicians for the last 3 years, and de-adopting that model has been a real challenge over the last couple of months. When I start to think about burnout and supporting our teams, running a CCRT list with 11 patients and now having a lot more end-of-life conversations, because I think we developed a particular skill in that, is certainly something to think about as we plan our HR staffing. We've gone from 4 physicians a week at our 3 sites up to 7, and despite that, we still really struggle. And so as we roll out that model, I think it's the right thing for hospitals, the right thing for patients. It certainly would put more stress on that point and deserves sort of contemplation.
All excellent points. And I certainly think we're going to build on a lot of what's been discussed. The staffing, I know we have a separate question on that, but I think you're absolutely right. The knowledge that was lost to retirement because of COVID was huge. And who knows how long it will take us to get over that and the impact of that. And certainly, I think some of the strategies going forward is how do we help the new hires to not only obtain that knowledge, but avoid some of the pitfalls that I think cause some of the retirements and things. And the access to care, that's huge. And I think that's what we're all committed to, and how we address that. Hopefully that will come up in some of the additional topics. And I like how you started with about the resource challenges that we all experience, Carol. And I think I'm actually concerned that the central depot that was created to address it has now already been, we're shutting that down, and hopefully we can come up with some strategies going forward that we don't repeat ourselves. With that, maybe we'll go to our next question. And I think, Mike, you're going to be starting us on question 2, whereas given the risk of future pandemics with infectious etiologies, does physical infrastructure and the size of critical care units change?
Yeah, so Dave, I think this is a really fascinating question. I think it's important to understand that the relationship between ICU bed numbers and pandemic success in developed countries, so that relationship is actually pretty weak. There are places that had lots of ICU beds that ran into trouble, and places that had very few ICU beds that managed. And so you can kind of see how any pandemic is going to kind of randomly affect things. Now, obviously, if you're an individual patient and you're saved by that infrastructure, then the relationship is very strong, right? It's quite clear. But I think when we think about this question, I think we have to be they're pretty clear about the fact that we're not going to build our way to pandemic proof. If we start pandemic planning with ICU infrastructure, if that's the beginning of our planning, then we're probably going to fail. We need to kind of zoom out, and we really need a provincial review of this pandemic in order to develop a plan for the next one. And so really, as a first order of business with respect to infrastructure planning, I think the critical care community needs to be advocating for a review of the pandemic and a plan for pandemic preparedness. ICU infrastructure is a small but important part of that plan, and I think it needs to be in the context of a whole society response to the problem. And I say this is urgent because I think there's a significant amount of kind of active forgetting going on right now.
Mm-hmm.
I think, and I understand it. Like, people are worn out, and we've got a mass of problems facing us in the health system right now, and nobody really wants to look back at this period because it was awful. It was really difficult. But I think it's important and necessary. And I think we also have to acknowledge that despite the incredible work our critical care community did and the high drama of rescuing health systems that were teetering, our success in the pandemic was due to public health measures. It was the tolerance of lockdowns without social unrest. It was more than 80% of Ontarians who were willing to roll up their sleeves and take an individual risk around vaccination so that they could contribute to the collective good. And we also had this robust scientific infrastructure, and I really want to emphasize this point, that was present and had been there for years before this, that allowed these miraculous vaccines to be developed, right? So you compare the 1918 flu, 20 million people killed in a world of less than 2 billion people. Here we are, we got 8 billion people in the world right now, and only 7 million deaths from COVID-19. It's a dramatic difference, and it's about what the public did. Some of those, a very small number of those people, were saved by ICU. So if I come back to the question, I'll take a stab at it even without the provincial review. I think infrastructure needs to be a part of a plan. There needs to be a provincial, regional, local piece to that plan. We can't know for sure when the next pandemic's coming. We'll have to make some estimates. There's possibly an increasing possibility it comes from some malefactors armed with their chat GPTs, but we really can't plan for that right now. So I think what we have to plan for is a respiratory pandemic. I think probably a virus that's going to do that. We've had this experience already, and I think we know some of the features that we're going to need to be able to manage it in the future. All the best pandemics have been respiratory. They've been viral, and I think the outcomes are positively, good outcomes are positively correlated with wealth and health literacy, and they're negatively correlated with population density and the social determinants of health. And so when you think about that, it already sets us up to know places that we need to direct some resources. Provincial and regional plans, if they were accounted for those realities, would kind of aim at the physical places. We know that, like this last pandemic, we had 4 hospital corporations that produced the preponderance of cases, and they're in places that were challenged relatively by these things that abet a pandemic. And so I think it would be sensible to think about actually physically putting some infrastructure into that area that could be opened and equipped. I think for most of us, our local infrastructure probably won't change that much, and we're kind of stuck with what we've got, and we're going to have to do the best of it. And most of that work should just be aimed at what's going on in the community. Finally, new hospital buildings should incorporate infection control things that we've learned, planning for scaling up into other areas. And I think that's really going to be the key area for us for most of our hospitals, is this idea of preparing to be able to scale up in areas that are not the ICU.
Thanks, Mike. You've hit on a lot of things. I like the act of forgetting, but the scaling up, the term that came to my mind is we need flexibility in our system, how we can adapt to different things. Marty, do you want to comment, and then I'll go to you?
Yeah, I like Mike, I had the same thought as Mike regarding the sort of the role and size of critical care in managing pandemics. One area I might sort of explore a little bit further is just the role of hospital-acquired infections. And certainly in many hospitals, the burden in critical care was driven by patients acquiring illness within the hospital. And so I think there's still a fair bit of opportunity to make care safer for patients. And it's not just going to be COVID, it's going to be flu, it's going to be pneumonias, and probably wound infections. We've learned that there's lots of little critters in the air that you can filter out and actually address through sophisticated ventilation systems. You know, in one of our hospitals, there is no HVAC system. So the air inside was the air that was delivered in 1970 when it was built. And I think that rather than just in critical care, it's a public health response that I think will get us there. And some part of that is providing safe care in our hospital systems. And as Mike sort of touched on the public health component, you know, there's been different narratives on how different public health restrictions contribute to the pandemic. And I think, you know, it's certainly beyond this table and this panel to sort of contribute to that narrative. But, you know, for those of us that recall the first lockdown in March of 2020, we were only days away from really exceeding our critical care infrastructure at that time, maybe closer than any because of the rate of growth we experienced. And it took, you know, 2 weeks for that to settle down. And I think I've heard it been criticized because it took us a long time to sort of get back to life or even doing surgeries at a hospital level. And so I think it's really worth a thought on how those measures worked. And was it really, what were the challenges, the lockdowns and the public health restrictions themselves, or just our inability to sort of move back and put our foot on the gas pedal afterwards, which I think in some respects happened. I mean, I can think of in Scarborough in particular, because we were certainly impacted during wave 2 around Christmas 2020. And those 4 days of people being able to go Christmas shopping certainly contributed to a lot more deaths just because that 4-day delay. And that was certainly, for me, the toughest part of the pandemic, because we knew how dependent our community was on those public health restrictions, because we weren't going to be able to solve them with care alone in ICU. Thanks.
I'll just add to that, you know, as I think about physical infrastructure, this is the time to really think about for the future. I remember when we were in the thick of it, you know, everybody trying to expand and just putting a bed where they could. And there's challenges with that, right? We have a lot of equipment that goes with a patient now that probably wasn't there 20 years ago. And some of our facilities are fairly old. So how do we make those spaces smart and really involve our staff with that? You know, as we talk about, you know, families at the bedside and whatnot, and there's a lot of equipment, how do we do that? And also just, you know, sometimes, you know, with new builds, just getting our architects to really work with staff about what's going to make sense. And I think about, you know, human-friendly design. How do we do that? So when we talk about our nurses, you know, how are we making sure there's not nurses in one bay alone? That, you know, how do we make groupings that make sense so we can support the care as a team too? So I think those are just some of the things I would add.
That's great. A lot of excellent points there. I don't know if Bernard or Michelle have a question or comment on this topic.
No questions from the crowd yet, but I encourage people to, as they listen to the discussion, like please, any questions you come up with, submit them and we'll get them out in front of the panel. It is an interesting thing, I think, this balance between how we learn from the pandemic and what we might sort of then implement, which is sort of pandemic ready, but may not always resonate sort of in the steady state. And that could be across, you know, whether it's an approach to how you look at funding or resourcing, or how you look at staffing, or how you look at your infrastructure. I think there's components to learn from this. And I think we always have, there is a balance, I think, with how things then function during a steady state. And it's not driven by the same fear and camaraderie and collaboration that we see sort of at the beginning of a pandemic. And so there's a lot I think we can learn. I've had people calling and say, you know, we should have individual ICU rooms, all with negative pressure, negative flow, and every room built in the province going forward should be this. But as Carol pointed out, I mean, that's not always practical, especially if you want to have expandable capacity. And it has its challenges, I think, when you think from a nursing perspective and how those are, you know, how you develop your ratios of nurses for patients, and, you know, making sure somebody's not left alone at on a shift when everybody else has gone for break. So there is a lot of pieces around this, I think, that are important to learn from. It's also important, I think, to keep an eye on the things that actually did work well from the planning that was done. The province has a pandemic plan. I totally agree with Dr. Sullivan that now is the time to sort of reassess that plan. And a lot of pieces of that plan were actually implemented. The IMS structure, the critical care piece in terms of our equipment and in terms of ventilators. And so you might not always see it if you're not sort of in that piece of it, but a lot of that was put into play and actually did work. But I think that it will never be perfect. And that's why we have to sort of take this time, as Mike said, in terms of looking at what we can learn from it and what would be modified. And I think part of it is also the governance, the accountability piece. Like, there's been a lot of change in the governance structure across the province with regard to healthcare. And I think now's the time also to just to solidify, if there's going to be a pandemic plan, where does that sit? Who operationalizes it? What pieces go into it? And there have to be a lot of people who participate in that, both right across the board of all providers and spectrums. The one thing I think that's interesting is also the IPAC piece. When we talk about physical infrastructure, sometimes the IPAC regulations changing hour to hour, and Dave, I know you're passionate about this as well, that even in the limited physical infrastructure that we had, it became further hampered by some of the inconsistency, I think, and that played a huge toll, I think, on some of the staff. That day in and day out sort of changing, and one day having a practice that they were doing because it was the safest, and that completely changing for the next day, and then leaving, then wondering like, well, what about yesterday? Was that not safe yesterday? Like, are we still looking out for the best interest of our staff, or are we? How do we change this? So there's a careful, thoughtful way, I think, to go ahead and not, throw out the baby with the bathwater, because I think there's been a lot of good in the system and we've learned a lot over time. But really it's a balance in terms of, practical, pragmatic learning from what we've experienced, and also it's a challenge sometimes with the dominant decision makers to put resources into the potential maybe. And that doesn't always resonate on the side of a bus stop on a campaign poster, but there's we have to be able to have a good way of communicating the need and the pressure, and that level of preparation that we have to have is worth the investment. It's kind of a rambling comment.
Oh, thanks. You've added a lot there, and I agree. Definite maybe sounds a little more positive than potential maybe. And I'll go to Michelle, and then we'll go on to the next question. But I think you've touched on the governance structure and standards. Certainly, those are important things. Michelle?
So there is a question from the audience. I'm just wondering what the panel's thoughts on how does the aging population affect infrastructure planning for the next pandemic when you factor in that added layer of complexity?
Who wants to take that hot potato?
I can start. I think it really talks about two things. Clearly, with a larger fraction of our population who are elderly, we're going to have more people at risk. And I think that really heightens this issue that we talked about before, or that Carol kind of mentioned earlier, and that is the role of critical care in getting upstream. I think we certainly saw some of this happen through this pandemic. With I think really our efforts were mainly pushed at the GIM population and trying to move those conversations farther upstream. But I think particularly as we start to develop a better and better understanding of the outcomes of critical care, like the Margaret Heritage work and all that kind of stuff, we're in a much more stronger position to be able to have meaningful conversations again about the value of ICU as or critical care as a dose of therapy for somebody and their circumstance. And I think we will be able to become better at having those kind of meaningful conversations with people.
I guess I would just add to that, within our larger ICUs, I do wonder if there's an opportunity to cohort people with similar ICU presentations that need similar care. And And what would that look like if some of our chronic patients are more cohorted together? I just wonder if that would be something we might want to think about too, as far as physical infrastructure and what that makes sense. And you know, does that also lend us different staffing models and different expertise that might be needed with certain populations? So that's just something I think we could think about.
Marty?
I like Carol's point, and that's something we've seen pilot projects for longer stay ICU patients that are not necessarily in a post-acute phase of their illness. And you know, if there's maybe one benefit of the pandemic is that we've seen a growth in ICU bed capacity across the province. We knew, at least the time I've been involved in critical care for the last 10 years, we've known there's been a 7% potential growth rate, and we certainly, in the number of patients, we certainly, I think, to some degree, are better prepared for the baby boomer generation developing critical illness now than we were as maybe a byproduct of the pandemic to some degree, and has forced us, because we were so stretched for so long, to think about alternative care models, alternative staffing models to manage the types of patients that are going to be different from how our system was originally designed.
That's great. I think that's a good segue as well into where is technology going to fit into that? Because I think it will give an opportunity to have dealing with different population groups in a different setting. When Bernard was talking about covering, I often wonder, you know, where the traditional eye on patient could potentially be augmented by video on patient with the idea. So I think technology will have a role. Marty, I think you're going to take this topic and see where you go with it, and then maybe we'll go to Carol and then Mike for comments, and then we'll get questions from Bernard and Michelle.
Yeah, so I was going to approach this a couple ways. So one is that I think with a lot of these technologies, one of the role that we'll have as a critical care community is really identifying the value to the system, value to our patients, and value to our healthcare workforce. And I think for some of the things I'll highlight, I think that's not yet been fully elucidated, but certainly one thing where I think we as a critical care community, both locally in our hospitals, but as a critical care system, have a role to play. And so I was going to highlight sort of 4 areas of technology that I think are either sort of in development or in actual use that help us take better care of ourselves and our patients. And you know, one was brought to mind on Sunday where I actually did 3 separate family meetings where substance decision makers were out of the country. And so being able to have a much more robust participation of substance decision makers through video and whatever else helped really cement the relationship that I was able to form with them and that they were able to appreciate for their loved one. And so while the pandemic often kept families out of hospitals, I think it did allow us a new opportunity to better engage those that can't be physically in the hospital that we couldn't take advantage of before. So that was the first one. The second area I wanted to highlight, and it's been brought up before, and that's the role of remote monitoring. So in March of 2022, 21, 22, I can't even remember any of the last 3 years. You know, we had, I think at one stage, 56 patients in our hospital system that at any other time would have been in an ICU. And the only way we were able to do that was through remote patient monitoring and having continuous vital signs measured and transmitted to our clinical team. And so, you know, that in and of itself, I think is a new adaptation and an opportunity for the system. I think we've continued to provide that level of care and that level of service to patients outside of the ICU, which has been so far a durable benefit. And, you know, I think of sort of the challenges we used to face from a capital perspective, you know, fighting with medicine over whether we got a gyroscope or they got a bladder scanner. And so just the opportunity to have that really capital investment in this infrastructure, I think is a real opportunity. So some of the things in our group we're starting to do, you know, can we monitor CCRT patients in a much more fulsome way than we did in the past, because we can get more or less continuous vital signs available on an ongoing basis. One opportunity is we're now using limited montage EEG in the ICU to start to think about sedation monitoring. And that's one thing I think our practice changed during the pandemic is patients, we sort of lost the light sedation opportunity that we worked so hard on for the better part of 5 to 10 years to optimize. And then as soon as you start paralyzing patients and deeply sedating them for 2 or 3 weeks at a time, it's been hard to de-adopt. So this is one opportunity that we're using because we happen to have monitors we didn't anticipate to have that we think can make a durable impact on our patients. Third area that I think was really brought to light, but I think has seen development almost independent of the pandemic, is just our data systems. So Critical has certainly done a lot of work with our operational data system with CSIS that I think having real-time data for the health system, for my local region, for my sites, has been fantastic, and one thing that we, as a system can leverage. I think there's other opportunity in looking at quality improvement dashboards that a number of hospitals have started to implement. So are we doing SVTs in patients that qualify for SVTs? How are we sedating patients? And there's a lot of learning in the system we can gather by further implementing these. And it takes some work from each hospital to sort of want to commit to that, but those opportunities certainly are there. And then the third one within the data systems is we're all in EHRs now. And so I think we're just beginning to scratch the surface of the data that's available to us. Part of my role at the science table was translating clinical practice guidelines. And a lot of it came to the REMAP CAP study, which was really based upon the ICNARC database in the UK and being able to deploy rapid, adaptable clinical trials and learning therapeutics in that circumstance from a really broad population. And I think given the way that the Ontario system operates, we have a huge opportunity. And so I think of the work that Jen Sang and Ali Binney have done with the Community Critical Care Research Network, and using those types of approaches to have a learning health system. I think there's a massive opportunity that we can take advantage of in Ontario. And then the last sort of big one that I wanted to touch on, and as I've I've been sort of hanging around the Rotman School of Management for the last 6 months, and you can't sort of walk 3 feet with someone mentioning artificial intelligence. And I think critical care really is poised to take advantage of this. We know AIs can now pass a medical board exam with scores greater than I could achieve when I studied for 10 months. So that's one piece. But we do generate vast amounts of data, and there's lots of potential intuitions and predictions that are going to come from AI. I think for a lot of clinicians, they find this scary, and I sort of recognize where that comes from. But it certainly is not going to replace clinicians and that insight and judgment at the bedside, but it's going to allow us to have predictions that we never encountered. So where I see that happening is things like predictive analytics. And so those at Unity Health are familiar with Signal One, which is one of a local group that's developed machine learning methods just to predict patient deterioration across systems, and our EHRs have access to this. I think that'll be something that we'll see and be able to take advantage of in the next couple of years. Another example being natural language processing, so taking text data, transmitting it into our health record. And certainly one of our colleagues, Chris O'Connor's lead of an organization called First History that's trying to take really more robust histories from patients and translating that into actionable information. Many of our patients that are getting imaging studies, their computer vision has begun to supplement that, not necessarily replacing our radiologists, but certainly being able to make sure that the images that we're getting reports we're getting are more accurate, and then in clinical decision support. So it's going to be a bumpy ride, I think, in the adoption of this. It's going to depend on having quality data, being really conscious of the bias that these are intrinsic to the AI systems. And I think for a lot of our clinicians, explaining it, because this is really a black box that shoots information back out at us. And so when clinicians can't go replicate the answer from the inputs that went in, I think that can be a scary situation. So that's going to take some time to get comfortable with and to generalize and to implement into our workforces. Those are the 4 trends I think that are critical or important.
Sure, I'll pick up on that. And I'll just admit from the start, I have a bit of a love-hate with technology and how this is going to fit. And, technology is great, but there's some areas that it's not serving us well. So even just remote monitoring, like that's great. But certainly when I was in clinical practice, looking at that patient is going into shock, feeling their skin, understanding what that looks like, their mentation going down. You don't see that on remote monitoring. And I worry about that. How do we figure that out? I also, wonder sometimes about the things we have, the technologies that we're developing and what we can do for patients. Like it's going to increase, but just that sort of adage, just because we can, should we? And I just really was very impactful to me once when I was in ICU speaking to a nurse who was a bit distressed and she says, "Carol, look at this patient. We're keeping him alive." And she was very just really expressive to me about what it was like to care for this patient with all this technology and the impact it had on her. And I think you just need to be careful with technology and making sure that we're having conversations about what the technology does for us, and is it really making a difference to patients, and not just see the technology as flashy things. I think for patients and the use of technology and using iPads to talk to patients, I think that's just wonderful. It makes it real for families, and sometimes it takes a few days for people to really understand, or a few times checking in with them, virtually, especially if a family aren't close, to really understand what's going on and help to figure out, what is really happening here. So I think that's really a wonderful piece of technology. But again, it takes more time with our staff too, and making sure that we're creating time for people to connect with people over technology, because it's different than connecting in person. And how are we skilling people to do that? So those are some of my thoughts. Mike?
Thanks, Carol. I want to come back to the research piece. Marty, I think you highlighted that. It's maybe a bit of a sore spot for me, because we've had an opportunity for a very, very, very long time, and the ability to be able to, we're a single health system in Ontario. We've just not been able to figure out how to be able to gather information on our patients, put it together, and just a common data set that we could use purposely for looking at interventions and what kind of things help people in our ICUs. And coming back to the pandemic preparedness side of things, there's, when a pandemic arises, there's no time to be doing randomized clinical trials and waiting for their outcome. It's not that we shouldn't be doing that, but we need information faster than they're going to be able to kind of give us definitive results. And so certainly the Remap Cap platform, other things like that, the reason that we were able to save as many people as we could with a simple intervention like dexamethasone is because we had a way to be able to understand that it worked. And we have that potential here. And we have, we've just not seen it as a way. And part of it's the disconnect that we have between our academic centers and our community centers. We just haven't been able to kind of, bring that all together. We've got pockets of just superb research capacity in the province, but it could mean so much more if we were able to just have as a mindset that everybody who entered our ICUs was part of a project to further our knowledge about how to look after people well.
Well said. There's a lot there. The ability to access the data, to communicate with different centers, and Carol, I'm always struck with the idea, just because we could doesn't always mean we should. And we'll certainly pick up that theme on in the staffing. I was wondering if Bernard or Michelle have questions or comments for our guests before we go on to the next question.
Not a question, but a comment. I guess it's interesting. I think I'm pulling from Carol and Mike's comments a little bit of the human piece, and I think we can have technology, and it's great, early warning systems, and it can help improve the tracking of vitals. But there still needs to be, at this point, a person at the end of receiving that to be able to interpret it, analyze it, help make decisions, even on the research front. And I maybe this is extrapolating and reading between the lines too much on what Mike was saying, but there's an opportunity to really improve how we collect data and how we have that available to for research and informing things that we do. But there was also with the very, I'll say, basic things that we were able to provide in terms of care, or IPAC rules and things like that. There was a valuable role in reminding people that they actually knew how to do their jobs, that they were doing the best that they could do. And I remember having these conversations with Mike early on in the pandemic and thinking that somebody would sometimes call and say they heard about, a research project going on about how to manage this or this in COVID. And it made them almost second guess that they really had a good skill set for already trying to manage those patients. And I think there's a balance. I'm not saying we don't need to do research to further our knowledge, but I'm saying that we also need to combine that with reassurance for people and colleagues that, yes, you're doing a good job. Yes, you can rely on your training and your skill and your experience, and you're going to do great. And there's a piece of that, the human part of like how that human part connects to then whether it's technology or advancements of how we monitor patients. That has to be something that we keep in mind. And listen, I'm not the soft fuzzy kind of guy. I'm a cold-hearted surgeon. But I think that I was just reminded of those things as Carol and Mike were sort of making their comments, and I think those are valuable pieces too.
And I think I kind of worry about the patient aspect in all of this because, they already had to go through a pandemic where they couldn't have their loved ones at the bedside, and we introduced more technology for them to be able to interact. And now if we're starting to depersonalize the healthcare a little bit by introducing more technology, that worries me a little bit too, because we didn't, there was a change in public mindset over the course of the pandemic where they started out banging pots and pans, and then they started to question more as things went on. And I just worry that if we start to introduce more technology and, pulling more data and caring for more patients remotely, that's not going to, further exacerbate that sense of uncertainty around their care and their care providers.
I think that's an excellent point, Michelle, and it's a beautiful segue for the next topic, next slide. Because you're right, remote monitoring with, the ROCS index that Marty's team introduced us to was excellent. But at the end of the day, it's those people skills, people coming to give the care that patients so deserve. And so with that, the question will be is how do we approach to care, such as staffing models, and will that change? And Carol, I believe you're going to start us off on this.
Sure, and this is a topic that's near and dear to my heart, and I could probably talk about it all day. So I'll try to be brief about this. And if anybody has any questions, please put them in. I think certainly we were challenged with staffing models during the pandemic, and we have learned a lot on that. And I just want to say how important team is to maintain, and that I really believe that we have a lot of different professions that are in critical care, and each profession really needs to take a hard look at what they're doing and who else can help. So our skill sets, so our scopes of practice, we're all regulated, but I would ask the question, are we really using all of our skill sets from the professionals that we have in ICU? Certainly with nursing early during the pandemic, there was a lot of talk about team nursing and, team nursing is going to be the answer to every problem we have. And, I had thought a lot about that during the pandemic, and team nursing didn't work. Nurses need to help each other. But the patients are so complex that, we wouldn't team nurse delivering a baby. We don't team nurse that. We take care of the patient, the family, but certainly helping. And who else can help? So one of the things that was quite successful during the pandemic for us, the organization I worked for, is we just added some PSWs just to run for stuff and get stuff. And when I say each profession really needs to look at what they're doing and what's taking up their time, it's really saying who else could do that? Who could help turn and lift under the direction of a regulated health professional? And I think that's really an opportunity for us to look and sort of break down some barriers of what we've done before. Again, maximizing those scopes of practice. Respiratory therapists also have a huge scope of practice. And I do wonder in some of our organizations, are we really looking at what respiratory therapists can do and how they can support care? And does everybody know what everybody's scope of practice is? I think, many of our, as professionals, we've been kind of territorial about what we can do and that this is my domain and nobody else can do it. And I'm not sure that's serving us well. And I think it's really important we start to think about that and really understand what each professional discipline brings to the patient care and as part of the team. And I think that can be facilitated with more interprofessional learning opportunities and collaboration. So, a learning opportunity doesn't need to be led by an emergency or a critical care physician. It could be led by another member of the team. And how do we start to appreciate what the different disciplines bring? We've got some stable chronic patients in our ICU, and we talked a little bit about that of infrastructure, but I think that's a real opportunity to look at our care models too. I know there's some, rehab facilities and long-term care facilities are taking vented patients, and, those facilities are doing that. And I think that really begs the question to us in critical care in hospitals, what are we doing, or what can we learn from other areas that are doing that? A patient's not the same patient. So instead of looking at, sort of the hard rules about 1-to-1 or 1-to-2, it's really like, what's the acuity of the patient and what does the patient need and who's the best person to provide that? Certainly a lot of our patients are very unstable, but some are just chronically with us and are quite stable. So I think, taking a look at that and just shaking up some of those old sacred cows a little bit. Some of our patients might need 2 nurses to 1. Certainly those ECMO patients, very, very heavy. So I think we need to think about that and involve our staff and not just following the rules about how many patients people get, but really thinking about what the acuity of the patient is and what the patient needs. Unfortunately, some of our rules around, how many nurses or whatnot really follow within our collective agreements. And when I talked about earlier caring for our staff, I've been pretty vocal about this, that, we got to shake this up a little bit. Certainly when I was talking to nurses in critical care, 4 12-hour shifts at a patient's bedside who's critically ill is really draining. So how do we do that? How can we do that differently? How maybe can we break up the 12-hour shift a little bit to give somebody an opportunity to do some teaching or some quality improvement or some research? Like, how do we change that up a little bit just to give people something different? There's lots of great work in ICU. So how do we give people just a little bit of a break or a little bit of a change, not to see that really distressing case for 4 days in a row? Certainly it's important for consistency in care, but again, I'm going to take that back to caring for our people and how can we do that? That's where the idea of, just having different things to do for periods of time, or making sure people are okay to put their hand up to say, hey, I need a break, and not feeling that they're less than because they need a break in that. So I think that's what we need to think about. One of the things was really interesting when I looked up early rehab and staffing models, what that could look like. And just, really keeping an eye on for our staff, thinking about, what does happen to the patient when they leave ICU? We see a lot of very tough cases in ICU, but what happens afterwards? And I was struck by listening to a patient who was a patient volunteer in the end, who had a long stay in ICU, and what her rehab was like, and lots of opportunities. We were talking at the time before I left the organization I was at about, doing some clinic work with ICU rehab patients. And wouldn't that be interesting to rotate some of our staff through that, just to see the other side? And again, helping to buffer off some of that moral distress and moral injury that people are having. So those are some of my initial thoughts on that. Again, I could talk about this all day, but I'll open up to my colleagues.
There's a lot there. And I'm going to go to Mike and Marty, but I've always been an advocate for staffing to acuity. And so I think you certainly cited that. And the idea of rotating the staff, to give them that reprieve. And there's also benefit to seeing the other end, the other sides of that. And, a lot of the skills they learn in ICU are certainly applicable to the wards, but conversely, skills on the ward are applicable. And you know better than all of us some of the challenges with the limitations with that. But I think your argument that it's helping the nurse, caring for them is potentially a way we can achieve it. Mike, do you have comments? And then we'll go to Marty.
Sure, Dave. I think one of the major pressures I think that we've got to acknowledge with respect to staffing models is funding. And I think there's and we're going to have to figure out how we can kind of make both of those things happen. We're on a kind of a trajectory currently that's going to be difficult to continue to fund at at this level. The traditional way that we've been able to manage this over time in the health system is to find, kind of lower cost providers who are going to then be aids and extenders to what's going on. I think that can chime with Carol's point about, specifically the idea of, who do we really need to do this job? What skills do we need to accomplish this job? And could we find a way? And so we've seen a proliferation of, classes of regulated health professionals and, aides that provide them, PT assistants and perhaps even respiratory therapy assistants, et cetera, that could do some work. It's always tricky about when we try and do this because the staffing to acuity model means you also have some mechanism for capacity. So you can be lean on the staffing side, but you need some capacity to be able to do some stuff. How we're going to acknowledge that, pay for it deliberately is going to be an important part of that question, so that we're able to respond to the needs of the hospital. Because I'm going to tell you, Ontario hospitals, are actually built, at least most of them that I've seen are built to function at about 18 hours a day, and the other 6 hours they spend like this. And so, the place that rescues those patients, the thing that's able to pull them back is often our ICUs, in terms of being able to kind of rescue those patients. So that's an important piece to consider as well.
Marty?
Yeah, I really like Carol's comments. We too struggled with team nursing. I think in part it was because how rapidly we deployed it. And I think in certain circumstances, it certainly helped us. And I think of some of our longer stay patients that were maybe a little less acute, but we could expand the role of that senior ICU nurse to help support those patients. But we certainly couldn't do it with all patients. And as we tried to expand team nursing into higher acuity patients, it certainly was I'll just say, to say the least, a challenging experiment. And I think similar for our senior ICU position. So we at our hospital, we employed intubation teams for some period of time. And after about 3 months of the pandemic, we realized it was our ICU physicians that actually intubated 92% of the patients at that point in time. And so we really were dependent on that CCRT type model. And I think for many hospitals, that's become really so fundamental in terms of how they approach care. I know there's been a great expansion in the CCRT deployment. And certainly 2 of our 3 sites, we didn't have physician-funded CCRT to begin with, but that got us through the pandemic. And I think the value of having a really senior nurse that could push drugs and a senior ICU physician available 24/7 to give us that 24-hour coverage to get support to patients outside of the ICU, I think really is something that we've adopted well in Ontario and maybe has an increasing role. And I really like the idea Carol suggested about giving breaks to our staff. Seeing the same patient, we do it for continuity's sake many times, the same patient day in and day out, but that can also be challenging. And so I think we need to hear from our practitioners, our clinicians, to see what they need as we adapt our staffing in our future, that there's a lot to learn from them.
That's great. A lot of excellent points. Maybe we'll go to Bernard and Michelle. I'm just cognizant of our time, that we have just under 30 minutes left, but Bernard?
So I had a comment that came in around, and this I think fits a little bit in terms of some of the comments that have been made by our panel in terms of the acuity of patients, I suspect, and also then a look at chronic vent programs in terms of where those are situated. I know at the beginning of the pandemic, when there was some capacity at some of the centers that do chronic ventilation, that a number of patients who were seen to be in the unit for a period of time, and maybe could have been weaned or maybe not, but they were, capacity was liberated in the acute side by moving some of these patients to the chronic vent programs. And in general, I think there's we had discussions around this while we've had this file with us at CCSO in terms of what are the pieces that need to come together to make improvements in that. But that was a comment, I think, around chronic vent programs. And I don't know if that wants to go back to the panel for any further comment or decision. Thoughts. I'll let them think about that for a second. I'll give you a little breather there, but only to add, I think that the thing around staffing models, I think, is one size isn't going to fit all. I think that's come out pretty clear in the comments. And I think also that it has to be recognition, I think, of the skill set that that the critically care trained nurse brings to the bedside, but not just that, but it's also accompanied by their passion for what they do. One of the comments I think, and that I heard when during the pandemic, was around the team-based model, is that some of the nurses thought it took away their ability to connect with the patient and the ability to look after the whole patient. And I think that's a piece that, if we aren't cognizant of that, I think that's some of the things that actually keep some of the nurses practicing critical care as long as they do. And so we have to be cognizant, I think, of some of those factors of where they get their joy in terms of being able to look after the whole patient, but also at the same time recognizing some of their skill sets where they're kind of muted or stunted. I remember, sometimes they're not, in some ways, they're not allowed to talk to patients' families about, end of life issues, because that's the domain solely of the physician. And I think there's ways that, some of the staff can participate in that is beneficial in terms of even preparing a family for having like a definitive conversation on that, where we should be able to look at some of their, not necessarily expanded skill sets, but where they have skills that we could be utilizing. So there's that really, I think, the culture of nursing and how nurses feel when they become critical care nurses and their interactions with patients and their families, that before we change too much of the model of that care, that, we have to consider that culture piece too.
Thanks, Bernard. Michelle?
I really liked Carol's idea of when, acuity and time permitted, giving the nurses and the other members of the care team a bit of a break from the bedside, engaging them more in quality improvement initiatives, maybe having them look at some data, look at some numbers, and try to manipulate that into meaningful change within the unit, because that might be another good retention strategy. I mean, I know the finances are an issue, and that's outside of my wheelhouse, but if you could engage people in other aspects of critical care where they could find passion and they could, renew their joy, that might be a really good retention strategy for the future, so that we don't have this efflux of all of these skilled and trained healthcare professionals leaving critical care because they're just so burnt out.
Can I just make a quick point on cost too, Dave, if that's okay?
Absolutely.
I hear that a lot about cost, but I was recently reading an article, and I'm sure it's more. The cost of turnover for a nurse in the States is $60,000. So if you think about the turnover we're experiencing, there is money. The cost for agency across Ontario is huge. So there's some money there. We just need to spend it wisely and for the long term. Because our cost of turnover, if we're not keeping a nurse, or any health professional for that matter, the cost to bring all those skills to a new nurse in ICU is huge.
That would have an excellent ROI if you look at the 60, and that's 60,000 Americans. So who knows what the Canadian is. I think we could talk about staffing almost for the rest of our time, but in the interest, I think we'll move on to build on what Bernard talked about. How nurses in particular, certainly the whole patient. And I think it's not just the patient, it's also the families. And with that idea, we're going to ask Mike, I believe, to start. What is the role of the family and how will it change and evolve?
Yeah, thanks, Dave. Carol, I got to say, I think your point's really, really good about the funding piece and about spending our money, with smartly, as it were. So, Dave, I'm going to tell you about, back in 2008, Rebecca Annison Brunet from St. Mike's wrote a paper called "The Future of Critical Care in Canada: A Patient-Centered Approach." And in the paper, they suggested that the next steps in critical care services in Canada should incorporate two major principles. One was a patient-centered approach to better respond to increasing patient expectations. And two was a realignment of critical care services to harmonize the level of care provided, intensive, intermediate, acute, and chronic, with patient needs. So I think one thing that this comprehensively demonstrates is the inertia in the system, since we're all still talking about the same thing here today and haven't made anywhere near probably as much motion on it as we would. That's specifically around the levels of care. But I think it's fair to say that we probably evolved our understanding of patient-centered to incorporate a family-centered approach as being kind of patient-centered. And I expect this trend to understand critical illness as a whole family disease rather than just the sum of medical conditions will probably continue. And more to the point, I think some of us are actually starting to believe that this is true. So that the shift there is not so much about what we say, but how much we really believe what we're saying. So I think we think that better care of families is actually important for our patients. So it's important to kind of know where you're going, you're trying to get to. And I think the place we're trying to get to is having the clinical team and the patient's family on the same side. All of them trying to hope and work for the patient to get better. And if that's not going to happen, to come to an understanding that it's not going to happen and deal with that information. Now that sounds easy when you say it, and it's not easy in the high stakes world of critical care, but I think that's where we're trying to get to, right, in my mind. And so having decided that we want to improve the relationship that we have with these families, I think we start by trying to see what we need to improve in ourselves. And so we look in the mirror and we look to see how we can contribute to that relationship. And I think there's several lines of research that are going to help us to prepare for a more mature, fulsome, and meaningful family engagement. So I think deliberate attempts to understand family satisfaction, like our FSICU, should move our understanding from kind of guesswork to actual information. I think that, again, I've mentioned this earlier, but the work of Margaret Herridge and Hannah Wunsch, who are allowing us to understand these trajectories of care for people and the outcomes of intensive care, will add to our ability to be able to inform our family and discussions. And there's lots of variation out there right now in Ontario. I think finding ways to kind of share information about what's working well would be really helpful. So if I'm out there looking for places to go, would be an important place to go. I think one challenge is how we calibrate our communication with families. So I work in a mainly surgical unit. The patients and families that are on a normal trajectory, usually a kind of a smile and a thumbs up is enough to kind of, that's what they need, right? But if they fall off the path, either in the OR or in the unit, it's important to reset those expectations, right? To draw that family closer onto the side of hoping that things are going to get better. And the expectations include what they can expect, in terms of regular information, sharing updates. In other units, the rhythm is kind of different, but the importance of identifying inflection points and then actively communicating a change in the relationship is equally important, right? So as the relationship intensifies, usually because things are getting worse rather than getting better, I think it's important for the whole ICU team to appreciate that this is a time to recalibrate. And often, the truth is, we're feeling kind of vulnerable at this point as well, right? Maybe things just haven't gone well, and like, where do we go? I think for these situations, like for these higher stakes, like high intensity situations, I don't think it's wrong for us to contemplate the idea of communication specialists. People who really have probably some counseling skills, people who can spend some time with these families, understanding where their dynamics are, because often we're just like wandering around and ready to step on some landmines, so that we can kind of bring back to the clinical situation, sit down with a more mature understanding about the relationship with the family. At a practical level, there's no particular reason why we can't ask these families to join our rounds every day as we do in person, but also virtually. We could easily kind of do this now with our EMRs and just, give them a text and then have them come into the, to join it through our EMR. And for sure, we need a better way to manage our long stay patients, right? Our whole model is just not set up to be able to look after these people properly. And, we've heard that smattered through our discussions here today. As I mentioned, in New Zealand, these patients were shepherded by senior nurses. They took them on. They sat everybody down once a week, updated the whole team on what was going on, including all of the attending ICU physicians, and really directed the care. it's a group we don't have, but we sure do need to focus on this group and develop a better strategy. So there you go.
Thanks, Mike. A lot there. Marty and then Carol.
Yeah, I was going to touch on the role of families in helping support our practitioners provide that care. And I think Bernard sort of alluded to this in one of his comments that, one of the things that I think our staff and clinicians were missing during the pandemic was that interaction and that support. And it didn't occur to me until I missed it or could go back to it, how really critical that was for my approach to providing care in the ICU. And I think as we sort of reframe, some of the elements that go into that, having 24-hour, it was difficult to convince many of our staff to reopen up the ICU to 24-hour visiting because we kind of got used to not having it. And as we've done so, I'm just reflecting on how important that is to our staff to know that loved ones are at the bedside. It's really difficult to communicate the severity of someone's illness over the phone. But to be able to walk someone through it, to hold their hand through it, I think that's such an important part of the compassion that our clinicians have, that it's something that we're working on and sort of redeveloping. And I think that's a critical piece to some of our burnout issues as well.
I'll just share just a quick story about somebody I know who recently lost their husband in ICU. He had a sudden cardiac event. She was a nurse. She did CPR and him in the home, into the hospital, into ICU, and he died. And when I was at their celebration of life, and she, I said to her, "How is the care?" And she actually said to me, she's the part that stands out the most for her, and her daughter's actually a nurse too, was that he was not going to do well, and the nurse brought a stretcher in, and she could get close to him and hold him for an hour before he actually passed, and they withdrew. And how impactful that was to that family. The whole care team was great, she said, but that moment helped them, or is going to help them, with a memory of a bad experience that happened, moving forward, in a memory they're going to have of the death of someone they loved a lot. And it kind of goes back to the technology. We have all this technology, but those high touch moments with families are really, really, really important. And it was a gift to that family that there was capacity to, within the team, to make that happen. And I really hope, as we plan ICUs, that we maintain that, because all families have challenges, but when you can make that situation and that ending fairly peaceful for that family, I think it makes a big difference.
That's so important, Carol. And I think that's a nice segue into our last question, where, although there's going to be a lot of changes, our capacity to still care and provide those types of opportunities for closure for our family is something I hope we don't ever lose. So with that, I'm going to go to Marty. I'm cognizant of the time. With all the significant potential changes, what aspects of critical care should we maintain?
Yeah, Dave, as you highlighted, a patient and family centered approach to care, I think, is number one, and will be durable through decades and through every ICU and every hospital system. I think three of the other areas that I would highlight are: one is the role of evidence-based medicine. So, we certainly saw lots of proposed treatments come up and go, but it was really those that we had evidence for, that we could actually generate evidence for in real time, that I think really, contributed to a lack of harm and potential benefit for all of our patients. Third was just how dependent we are on interdisciplinary care. So being able to coordinate the best ideas from everyone, using our nurses, pharmacists, personal assistants, optimizing those through everyone's skill and experience into patients and the families as well, as we highlighted. And the last thing is, maintaining the regional systems of care that not only occurred in critical care, but certainly some of the work I've done sitting on the GTIMS that really allowed us to care for our patients because we functioned as one integrated system. Saved us. It certainly saved us in Scarborough. I can say that to a large degree, but really helped ensure that there was access for patients, that the quality of care was maintained, avoided sensible events, and that those committees and that set of infrastructure that developed in real time, I think is something that will have durable value, not just for COVID, but as part of our seasonal surges, as part of getting back on track from patients whose surgery has been delayed and deferred, to create the capacity throughout the entire system. So that's elements I wanted to highlight.
Thanks, Marty. Regionalization is something I'm certainly interested in, but I won't hog the time remaining. We'll go to Carol and then Mike, and then to our other exec members.
Sure. I'll just say, again, how important the whole critical care community across Ontario, how important that is, and how that, the infrastructure was there before, but during the pandemic, it just really pulled together, and just maintaining that really well. I think a lot of great stuff got done. And, that just goes right down to units with teamwork, and how those teams work together, and just making sure that our ICUs make sure they continue to be high touch.
Yeah, Dave, I'm going to just agree that, I mentioned earlier the fact that we had an infrastructure, a scientific infrastructure that allowed us to deliver vaccinations in a just mind-bending short amount of time that were highly effective. The fact that we had a critical care infrastructure already existing in Ontario to be able to leverage onto was really, really important. Those people kind of knew each other beforehand. They were able to then, they weren't spending time trying to develop a relationship, understand what's going on, do some things. That infrastructure then meant that we were in a position to be able to respond really rapidly, effectively to to a need, and that included all of the ICUs who could see who could understand their place in this response. Right, and that's because the infrastructure was there already, and that's CCSO and what it's done for us. So that aspect of critical care for sure is is going to need to, in my opinion, need to stay in some however it's going to be.
Couldn't agree more, Mike. I think the relationships, we always talk about policies and structure, but at the end of the day, it always comes down to relationships. Us texting each other,
Exactly.
reaching out, and I do think that we should acknowledge and credit CCSO, and I think we all help develop those relationships. We have our own networks, but more importantly, as leaders of the networks, we're able to meet each other and share best practices and share ideas, as well as call on for favors. So with that, I think that's a nice segue. I'm going to ask Bernard if you have any questions or comments on this, and then I'll go to Michelle, and I think we're almost out of time with that, but Bernard.
Yeah, thanks, Dave. Excellent comments by the panel. I've really enjoyed the discourse and discussion so far today. I think around obviously there's a role for patients in critical care units, not just from the perspective of being able to inform you about the patient and sort of their history and preferences and things like that, but also, that I find a lot of the staff also appreciate that piece of being able to comfort or support the family. And that's an important part of what they do. And I think, there's a huge role there. The interesting thing sometimes I think is around when we talk about patient-centered and the perception that patient-centered is everything that the patient wants or everything that the patient thinks they want. And sometimes patient-centered is suggesting to the patient what is valid treatment or not a valid treatment, and not suggesting it. And I think we're going to see a little bit of movement. I think that, as per other specialties, people don't offer things that aren't going to benefit patients. And part of patient-centeredness, I think, has to come back to the things that we offer, are they actually going to benefit the patient? And that should be considered part of patient-centered. And I think there's a piece that has often been, I don't want to say misinterpreted, but I think the focus has been sometimes, for lots of reasons, on just what the patient wants or what the family wants. And sometimes what the family wants isn't always what the patient would have wanted. And so there's a lot to tease out there sometimes, I think, especially in looking at the role of the family, but also as it relates to decision-making and end-of-life care planning, and how we sort of learn, I think, from some of the pieces, because I can tell everybody has their stories, I think, through the pandemic of patients that may have been transferred that were, you sort of start to think like, okay, anybody have a conversation about the long-term prognosis of this? And I think, to Mike's points, where we have a lot to learn, I think, from some of the work that, like, Margaret Herridge is doing in her research. Now the challenge is going to be, let's implement some of that. How do we incorporate some of that, what's being learned, into some of the conversations of the consequences of prolonged critical care stays. And I think, just in keeping with everybody's comments, there's a human touch to everything we do. And I think we need to remind ourselves that despite what we can incorporate from technology and from AI and things like that, there's a human piece of this, especially, I think, in critical care, because it does often represent the last phases of somebody's life. And those are things, I think, that we can't necessarily negate per se. And it's often, I think, a privilege to participate in that phase of life, especially for people who come in who we are effectively strangers to us. Like, we don't always get to know, their whole life story, but you're there for that phase of it, and it should be considered a privilege, and we should make sure that we have that human sort of side to it. I know where all this soft, fuzzy stuff is coming from today.
Well, you may think you're cold-hearted, but at least you have a bit of a heart there, Bernard, with that. Michelle, and then I'll ask for any final comments from our speakers, and then we'll have to end, unfortunately.
Just really quickly, one of the things that I found beneficial to our regional system was the communication and collaboration that we had with the community hospitals. So trying to do some in-the-moment teaching with them, helping to empower them to be able to hang on to one of those sicker patients that in the past would have automatically been brought to our tertiary care system. So, we talked about networking and having that collaboration, and I think that's something that definitely needs to be promoted moving forward, because I think everybody anticipates future pandemics, and hopefully not anytime soon, but at least we've got the framework in place to try and better support our regional partners.
Nicely said, Michelle. Maybe for final comments, I'll go to Marty, then Carol, then Mike, and then we'll have to close. We'll also put up our survey. We do ask people for feedback on this. We certainly appreciate that. Marty?
Yeah, I really appreciated the discussion today amongst the panelists. And for me, it was an opportunity to reflect on the last 3 years, which have been a whirlwind. And I think, what I've heard today is a lot of the things that we knew even 4 years ago. What's at the center of our approach to care? That's the patient. Getting back to that, getting back to the focus that we developed for a number of years to move us forward, I think to me have just been reaffirmed by the challenge that we went through, but also that we've learned some things regarding our ability to rely on our colleagues, to rely on the systems of care, to rely on the things that we thought were going to work that did hold us through. And so it's nice to know that those still exist, that the framework I had in approaching my question of are we providing the right care and the best care to patients still exists, and there's more work to be done, and look forward to taking on with all of you over the next years. So thanks.
Great. I'll just end by saying working with critical care during the pandemic has been a highlight of my career, and just really enjoyed the teamwork and the community, and just working through all the challenges. And I just want to say thank you to all of you who are still in critical care, and it's really good work, and all the crew at CCSO. You have an exciting future ahead, and as much as we've talked about the challenges, there's lots of strengths to draw on to, and I'm excited to see where critical care is going to go.
We love you too, Carol.
Thank you.
And it's great to have you here. I just want to come back and try and drive home this point again about how necessary it is for us to go ahead and have that the critical care community should be advocating loudly for pandemic review. when we talk about the fact that, what are the things that we need to keep in critical care, and one of the things that we need to keep is CCSO. Well, the reason that CCSO is there is because we did a review after the SARS pandemic and realized that we needed an organization like that. So there are meaningful lessons that can be learned, that we can implement, that can have a significant impact on what happens the next time around. But that will only happen if we actually undertake the review.
Nicely said, Mike. And we did a review in Ontario East, but I do think that needs to happen throughout Ontario, certainly, because there was a lot of great work that was accomplished. And I think it's going to be the, for want of a better word, highlight. It's going to be of my career, and I'm certainly I'm not alone in that, and the opportunity to put our skills to the fullest use and actually trying to make a difference is something I think will be the most rewarding aspect of my career. So with that, I just want to thank our speakers for this. We could have gone on for even longer. Thank you to our audience who stayed with us, and hopefully this new different format will be of interest. And if it is, please give us that feedback. Before I go to Dr. Lawless for some closing comments, I just certainly want to thank Critical Care Services Ontario team, who helped us put this on. Certainly, I asked for them to do a picture of themselves, and I can see that they didn't. So we'll have to have a harsh discussion with them later. So Maria, Nancy, Lynn, and Cindy certainly have been there, and I'll give you a harsh talking to for not putting up your pictures. And likewise, the OC3PR exec, Mike, we miss you, but we, certainly are appreciative of Michelle, Jose, Neil, Jennifer, and Crystal, and last but not least, Bernard. So with that, thank you, everyone. You can see that we're planning for September 2023. And so please send us your suggestions, and I hope everyone has a lovely summer. And Bernard, I'll give you the final word.
Great, thanks. And I won't, despite my ability to go on at length, I will keep it brief. And I just want to thank the panelists for participating today. I think we've had great perspectives from all of your experience and expertise, and that's very valuable. I guess to Mike's point, it doesn't necessarily substitute for a full sort of debrief on how we can learn from the pandemic going forward. I think that has to be from a multiple sort of sector piece as well, not just from our critical care perspective. But we need to have a strong sort of presence in articulating our experience and what we could learn from that. It's been an interesting experience, and I think everybody has some very good takeaways from how we do better and how we continue to better, despite the planning that may have been done before and the initiatives we could have implemented. There's still some opportunity, I think, for us to grow and improve. And I do want to say thank you for commenting on the CCSO team, especially for some of the supports that they provided during the pandemic, and always for OC3PR. There is a need, I think, for that ongoing sort of central coordinating group in the province to be able to create the opportunity for advocating for resources, but also to ensure that we're not doing 10 different things across the province so that it wouldn't be able to mesh up when we have to all come together. So that's an important piece of it. So thank you. And thanks, Dave, for your incredible hosting as you always do. I could listen to a recording of just your voice sort of as because it's calming and soothing. That things get stressful here, so I'll have to remember to tap into these YouTube sessions. You can do podcasting. I think that's it. So if nothing else, thank you very much, everybody, and enjoy the rest of your day. Any feedback, let us know, fill out the survey. Thanks.